In this video, we shall be talking about the diagnosis of intermediate uveitis, diagnosing based on the history and systemic examination. We shall be looking at the etiology specific investigations that must be ordered in the case of intermediate uveitis, how to suspect and diagnose multiple sclerosis, suspecting and diagnosing sarcoidosis, suspecting and diagnosing tuberculosis, Lyme's disease and cat scratch disease, which are the major causes of intermediate uveitis. Apart from that, we shall look at the specific ocular investigations and the role of fundus fluorescent angiography, OCT, and UBM in a case of intermediate uveitis. So now let us study how to diagnose intermediate uveitis. So in the previous video, I explained that there are so many causes of intermediate uveitis. We have some infective causes and some non-infective causes. However, the most common causes of uveitis or the intermediate uveitis that we see in the clinic are basically undifferentiated intermediate uveitis, sarcoidosis, multiple sclerosis, and among the infective etiology we have the tuberculosis. Now let us try to diagnose each of these conditions one by one. So first we'll talk about the multiple sclerosis leading to intermediate uveitis. So often if you see a patient with signs and symptoms of intermediate uveitis, which we have discussed in the first lecture or in the first video on intermediate uveitis, and along with that, if patient gives symptoms of some paresthesias like burning in the extremities, electric shock like sensation, tingling sensation, tightening of the muscles, pins and needles, then definitely you have to think about multiple sclerosis, right? So if there is a history of loss of sensitivity or paresthesias of the hands, arms or legs, and particularly in women of age about 20 to 50 years, and along with that sometimes you're going to see granulomatous anterior uveitis as well, right? So if you have this history, if you see intermediate uveitis, and moreover if you see other associated signs which suggest multiple sclerosis, which are granulomatous anterior uveitis, history of optic neuritis in the past, or signs of optic neuritis in the present clinical examination, and apart from that sometimes even superior vasculitis, which I again described in detail in the first video on intermediate uveitis, then you have to think that maybe the cause of intermediate uveitis in this patient is multiple sclerosis, and then you go ahead and do neurological examination or refer the patient to a neurologist, and then they can order a neuroimaging for this patient to rule out demyelination, right? And what did I tell you in the first video? That intermediate uveitis usually can cause peripheral periphlebitis or peripheral vasculitis, right? And most of the time it is usually an inferior vasculitis. However, if you see a patient of intermediate uveitis with superior vasculitis, always think in terms of MS, that is multiple sclerosis. Now here in the first picture, you can see over here these white lesions, and these are basically your periventricular white lesions, and these are the demyelinating lesions that you see in multiple sclerosis. Apart from that, you can see these whitish lesions here, and you can see the vessels is not very clear here, right? So it indicates that there is some amount of vasculitis going on in this patient. And definitely, as I told you, optic neuritis is a very common association with multiple sclerosis, and if you see a patient of intermediate uveitis who is presenting with optic neuritis or some signs of the sequelae of optic neuritis like pale disc and loss of vision, and you go ahead and do a neuroimaging and you find these white lesions, then you have to think in terms of demyelinating disorder, that is the multiple sclerosis. So according to the SUNS working group, that is standardization of uveitic nomenclature, it says that there is a criteria for diagnosing multiple sclerosis associated intermediate uveitis. So what is the criteria? First of all, there should be evidence of intermediate uveitis. And what is that evidence of intermediate uveitis? It is presence of vitreous cells, vitreous haze, and There should not be much anterior chamber cells, and there should not be retinitis or choroiditis, because in that case it means that patient actually has anterior uveitis and posterior uveitis and not intermediate uveitis. Okay, so if at all the patient actually has anterior chamber cells, it should make sure that the anterior chamber inflammation is less than the vitreous inflammation to call it an intermediate uveitis. Okay, so once you have diagnose the patient as having intermediate uveitis, second thing is diagnosing him as having multiple sclerosis, and that is done using the revised McDonald's diagnostic criteria. Okay, now at the same time, it is very important that you rule out all the other causes of intermediate uveitis which can commonly occur. So this would be definitely syphilis serology, number one, and second is sarcoid. So rule out sarcoid, rule out syphilis, and if the patient lives in an endemic area where the Lyme disease is prevalent, then you can actually rule out the Lyme's disease as well. The reason for doing this is because all these three, syphilis, sarcoid and Lyme, can also present with some neurological symptoms similar to that of multiple sclerosis. So make sure you rule out them, and then you diagnose multiple sclerosis based on the revised McDonald diagnostic criteria, and then you label the patient as multiple sclerosis, or you refer the patient to a neurologist. Now, we have two videos on optic neuritis and multiple sclerosis on our channels, which are titled as given in this slide. Now moving on to the second cause of intermediate uveitis, again a common cause, and that is sarcoidosis. Now usually sarcoid patients usually will have history of fever, fatigue and night sweats, and they are quite similar symptoms that you see in case of tuberculosis as well. Now if a patient comes to you with such symptoms, now you go ahead and do your systemic examination, and specifically you do your Schirmer's test. Okay, so you do your Schirmer's test. The reason why we do Schirmer's test is because usually sarcoid affects the lacrimal gland, and in these patients a predominant history would be presence of dryness of the eye, and therefore you can go ahead and do a Schirmer's test. Apart from that, you do CT chest. You can also do a Montus test. Usually the Montus test is negative in case of sarcoid, and CT chest will basically show bilateral hilar lymphadenopathy. Okay, so that is important. Apart from that, you can also do a serum angiotensin converting enzyme test. Okay, however, this is not a screening test for sarcoid. Remember, in ophthalmology, when we are trying to diagnose sarcoid, we basically rely more on the signs of sarcoid than on relying on the serum ACE levels. Okay, so that is important. So basically on a chest x-ray or on a CT chest, you will basically find this bilateral enlargement of the lymph nodes on both the sides. Okay, that's what is bilateral. So this is called bilateral hilar lymphadenopathy. So often in sarcoid, you find a sudden onset of erythematous, really firm, solid, deep nodules, and sometimes they can also present in the form of plaques, and they are really painful on palpation, and they are mainly localized on the extensor surface of the legs, as I mentioned, right? So these are called erythema nodosum. Apart from that, there are some ocular signs as well, which will point the diagnosis towards sarcoid. So you can see those granulomatous mottle fat keratic precipitates. Apart from that, you can see sarcoid nodules in the iris. You will also see these nodules like this. And what is seen in sarcoid is that you will see the sarcoid nodules to be present even on the trabecular meshwork. Okay, so that is one thing. Apart from that, really tall peripheral anterior synechiae will be seen in case of sarcoid. Then snowballs can be present, and one more feature that you see in sarcoid, which you should remember, is the presence of multiple inferior hypopigmented lesions. Okay, so remember the systemic symptoms, the systemic signs, and the ophthalmic signs in case of a sarcoid, right? So here again you can see inferior snowball lesions, and on the HRCT you can actually see this bilaterally enlarged lymph nodes, that is bilateral hilar lymphadenopathy. Now, coming to the third important cause, and actually, I would say that in endemic areas, tuberculosis actually forms a major bulk of intermediate uveitis. A patient who has tuberculosis associated intermediate uveitis might have fever, chronic cough, night sweats. Often there will be a history of significant weight loss. There will be a history of TB contact. They might be hailing from an endemic area of tuberculosis, like in the South Asian countries. So in those cases, you have to suspect tuberculosis, and the usual investigations that we order for the diagnosis of tuberculosis basically are a chest X-ray. Okay, you can go ahead and do even a high resolution computer tomography, and you can go ahead and do a Montague's test, quantiferon gold, and also immunoglobulin gamma release assay, which is also abbreviated as IGRA. Now, the more specific and sensitive tests over here are the quantiferon gold and the immunoglobulin gamma release assay. So if the suspicion of tuberculosis is really high based on the symptoms and the signs that you find on examination of your patient, it is advised that you go ahead and do these better tests rather than relying on your Montague's test. Apart from that, there are some very specific ophthalmic signs which have been described in literature related to the ocular tuberculosis, and some of those similar signs you might find in intermediate uveitis because of tuberculosis, which will help us in clinching the diagnosis of tuberculosis. So what are those signs? Number one is the presence of occlusive vasculitis. So we know that there is vasculitis component in case of intermediate uveitis. Now, sometimes because of that vasculitis, there will be occlusion of the vessels leading to features similar to that of occlusion, that is multiple hemorrhages in the periphery. So that is called occlusive vasculitis, and that is seen in case of tuberculosis. Apart from that, in the periphery, you will see that the vessels will be really tortuous, and sometimes just below the vessel, you might see certain scars, and those are called subvascular scars. So all these three really can actually lead you towards a diagnosis of tuberculosis, right? So this is example here, this from this paper. So in the first picture, you can actually see there's dense vitritis, and you can see the snow banking here. And apart from that, you can see in the second picture these black lesions which are present just below the blood vessels, and these are basically your subvascular lesions, and they are actually suggestive of tuberculosis. Now, the fourth disease that can lead to intermediate uveitis, and that we'll discuss, is the Lyme's disease, also referred to as the borreliosis. Right? So this should be suspected if there's a history of tick bite and arthritis of the knee, right, in a patient who is hailing from the areas which are endemic for Lyme's disease. Now, when you talk about India, in Karnataka and parts of Orissa, there are areas which are basically endemic for Lyme disease, and if a patient hails from those regions and he also has this history of tick bite and diminution of vision with floaters, then you might have to suspect the presence of Lyme's disease. Right? So in those patients, the investigations that you carry out is basically the serum IgM and IgG, which are ELISA based tests for the Lyme's disorder or the Lyme disease or the borreliosis. Right? Now, apart from that, here again you can see anterior uveitis associated, and the patient usually have nodular episcleritis as well. Now, the most common sign of infection with the organism or the spirochete Borrelia is basically the presence of this expanding red rash, and this expanding red rash basically is known as the erythema chronicum migrans or erythema migrans, right? So it basically appears at the site of the tick bite, usually about a week later. Okay, and this rash is neither itchy nor it is painful, and approximately 70 to 80% of the people who are infected with this Lyme disorder will actually develop this rash. Okay, so sometimes diagnosis is really difficult. Now, apart from this erythema chronicum migrans that you can see over here, which looks like a target sign as well, the patient is also going to present with arthritis of the knee. right? So they will have this painful arthritis. Apart from that, if you look for the ophthalmic signs, sometimes you might even find the tick attached to the lashes of the patient, and these patients can actually develop nodular episcleritis, right? So here's a tip, that if you find a case of nodular episcleritis and there's history of tick bite, do suspect Lyme disorder or Lyme's disease, right? Now, the fourth disease is actually the emerging disease, which is a great masquerader, and that is syphilis. So syphilis can actually present as anything, any of the uveitis. It can present as just anterior, intermediate, posterior, or a span uveitis as well. Similarly, when we talk about skin lesions as well, syphilis is considered to be a greatest masquerader or a greatest mimicker. It can actually mimic multiple disorders, right? So usually in syphilis, you will have the signs of dermatitis. So whenever you see skin lesions, always suspect syphilis and always make sure that you exclude syphilis out of your differentials, right? Now, so the patient can actually come with this chancre like lesions, and this can be chancre or chancre, whatever you want to call it. It can be present on your genitals, or it can be present below the labial surface, right? Apart from that, such macular papillary lesions can be present on the chest. You can have palmar lesions or plantar lesions, okay? Whenever you find these palmar plantar lesions, make sure that you screen the patient for syphilis, right? It's a very, very important point. Then, what tests are you going to use in this patient? Okay, so you can use either VDRL or TPHA, but it is very important that you use these two tests, that is TPHA or the fluorescent treponemal antibody absorption test. It's very important because these are very sensitive and they are used for screening. Once a patient is affected or infected with syphilis, these tests are going to remain positive throughout your life, right? So it's always important that you depend on these tests for the screening purpose and don't rely on VDRL, right? So VDRL is a more specific test. However, it is not used for screening and it is only used for guiding the treatment response. Now coming to another disease which can actually cause intermediate uveitis, and that is cat scratch disease. Now usually there will be a history that the patients own cats basically as pets. There will be pre-auricular lymphadenopathy. Sometimes this cat scratch disease can lead to conjunctival granuloma as well, right? So as you can see in this patient, there's actually an ulcerated papule which is present on the cheek, which is caused by a cat scratch, and then 2 weeks later the child actually developed submandibular lymphadenopathy as well, right? So in such a clinical presentation along with intermediate uveitis, you have to suspect cat scratch disease, and the organism here is the Bartonella henselae. So, what are the investigations that we do after a proper history from the patient? After taking a proper history, we actually carry out the visual acuity testing, we do slit lamp biomicroscopy. Intraocular pressure measurement is very important because, as I mentioned regarding the complications of intermediate uveitis in the first video, you would remember that intermediate uveitis can be complicated by raised intraocular pressures and sometimes even with hypotony. So, measurement of intraocular pressure becomes extremely important. Apart from that, make sure that you carry out a detailed fundus examination with adequate scleral depression to not miss those snow banking lesions and neovascularization in the periphery. If that is not possible, you can even go ahead and do a wide fundus imaging like the Optos, right? Apart from that, many patients are actually given an Amsler grid that is given to the patient so that they can actually monitor their symptoms and present early whenever they see some alteration in the, or whenever they find some metamorphopsia in their vision, and that metamorphopsia should alert the physician or treating physician about the macular edema. That is one complication of intermediate uveitis. Of course, fluorescent angiography and optical coherence tomography, they have a role in case of intermediate uveitis. So let us see how fluorescent angiography basically helps. Now, fluorescent angiography basically helps us to assess the presence, and also it can tell you regarding the extent of cystoid macular edema. Apart from that, based on the leakage that you find in fluorescent angiography, You can also examine the peripheral retinal vasculature and see if the vessels are leaking. It means that there are signs of perivasculitis, or it means that there is periphlebitis, right? Apart from that, it can also show you certain areas of retinal non-perfusion and areas of neovascularization. Also, you can find disc activity or activity of vessels on the disc. If you find leakage on the disc, that is called disc hyperfluorescence or hot disc, and that basically shows that there is inflammation going on in the patient. So these are 4 indications of doing a fluorescent angiography in a case of intermediate uveitis. Now, in these 2 pictures, you can see that in the first picture, these are the vessels and the vessel seems to be leaking, right? You can see leakages, you can see hyperfluorescence around those vessels in the periphery. So it basically means that there is active component of periphlebitis or peripheral vasculitis in this patient. In the second picture, you can see hyperfluorescence in the macular area in a petaloid fashion, and this indicates that there is presence of cystoid macular edema. Now, your slit lamp biomicroscopy also can help you to detect the presence of cystoid macular edema using a good 78 diopter lens or a 90 diopter lens. However, if you're not sure and for confirming the diagnosis, you can actually do an optical coherence tomography or an OCT. And on OCT, you will find the cystic lesions which are present in the retina, and this will indicate that there is presence of cystoid macular edema. Right now, apart from that, also sometimes you might see a presence of a membrane in front of the macular area, and that is called an epiretinal membrane. Right, so 2 conditions where it can actually help you. Your OCT is to detect cystoid macular edema and epiretinal membrane. Right, now what about ultrasonography? Ultrasonography, basically you can do a UBM, okay, in these patients, and this UBM is basically done specifically in those patients where the view is restricted because of a very small pupil, or when there's a presence of cataract. So when you do a UBM, you can actually or an ultrasound, UBM basically is based on ultrasonography. So when you do a UBM, you can actually find out the extent of vitreous debris or the amount of vitreous cells which are present in the vitreous. And so sometimes you can also find some membrane like structure which is extending behind the lens, okay, which is present behind the lens and extending on top of your pars plana or pars plicator of the ciliary body. Now, such fibrovascular membranes are basically referred to as the cyclitic membranes, and they have a role in causing hypotony of the eye. Right, apart from that, sometimes you doing a UBN, you can also exclude some granulomas in the periphery, and those granulomas basically could be toxocara granuloma, because all of them actually come to you with somewhat similar picture of intermediate uveitis. Now, this image over here actually demonstrates to you what is meant by a cyclitic membrane. So behind this IOL, you can actually see this membrane which is actually coming from pars plana and extending behind the IOL. You can see it as a whitish membrane here as well. So this indicates the presence of a cyclitic membrane detected on your ultrasonic biomicroscopy or UBM. If you liked our content, make sure to subscribe to our YouTube channel. Also, you can actually join our YouTube memberships, and I often get a question as to how do I join the membership. So let me demonstrate that to you now. In order to become a member of Insight Ophthalmology, first you need to watch any video of Insight Ophthalmology. For example, right now I'm watching this video on mastering iris anatomy. So here below the video, you will see there are 2 buttons. One is a join button and one is subscribe button. So make sure you're subscribed to the channels. Okay, so this is what happens when you subscribe to the channel. And after that, you can see that on the left hand side, there's a join button. So using this join button, you can actually join the memberships. So once you click on the button, you will be able to see that there are 3 levels of memberships which are available, and their perks are actually depicted on the right hand side of the dialog box. So you can choose the membership which is best fit for you, and once you actually choose it, you can click on the join button and then you can do the purchase according to the method which is best fit for you, right? So that's how you actually join these memberships. And often I get a question that people are not able to join memberships, they're not able to see join button over here. So the reason could be either you're not logged in, so make sure that you are logged in into your YouTube account. And the second thing that you need to make sure is that sometimes the YouTube memberships might not be available in your country because of some security reasons and because of some private policies of YouTube and the government in your country, right? So in those cases, I also cannot help you. I really apologize that I'm not able to help you in that case, right? And for the rest of you who are lucky to see this join button, you can go ahead and click on it. And that's all. I hope it was useful. Thank you and have a nice day.